So, hi class. We are now going to have a session on joint and soft tissue pathology. We have a total of 7 slides for today, starting with osteoarthritis is 200. We have 196, that is rheumatoid arthritis. Slide 13, that is gout. Slide 22, fibrosarcoma. Slide 23, rhabdomyosarcoma. 25, liposarcoma. And slide 101, leiomyosarcoma. So let's start with slide 200, which is osteoarthritis. So osteoarthritis is the most commonly identified joint joint disorder or joint disease. It is also called degenerative joint disease. It causes degeneration of the cartilage, and it will result in structural deformity of the joint as well as joint failure. In 95% of cases, it is idiopathic. Okay, so that's what we call as a primary osteoarthritis, and this is attributed to the aging process. 5% would be secondary osteoarthritis, wherein our patients would be younger. They can have predisposing conditions like having an injury. That's why osteoarthritis can be seen in athletes. Diabetes, obesity. Okay, so with gender, the affected joints can also be different. For males, usually have hip deformities, and then for women, it's usually the knee and the hands. Okay, so in this case, the degeneration of the chondrocytes or the cartilage or the collagen type 2 would exceed the synthesis, and the degeneration here would, or degradation, would be caused by the metalloproteinases being present. So what we would see in the slide would be the presence of the, so this portion would be the cartilage. Lower portion, of course, you have here the bone. This would be the surface of the articular cartilage, which would be made up of hyaline cartilage. And very characteristic for this particular slide would be the presence of the so-called eburnation. Okay, so eburnation, fibrillation. So you can see the presence of the projections, okay, brought about by the degeneration of the cartilage. And you have a lot of these fragments, okay. The fragments here are made up of cartilage, although in the book it says if they're sloughing up to the lower portion in this area, it can include portions of the subchondral bone. So these are what we call as the loose bodies. So loose bodies would be seen in osteoarthritis. So there would be fibrillation of the cartilage, presence of loose bodies, and then you go to this portion. Notice that there would be a sloughing of the cartilage of the articular surface until such time that what we would see on the surface would now be the bone. It's not the cartilage, this would be the cartilage, this would now be the portion of the bone. So the bone would portions of the bone would now become the new surface instead of the cartilage. Being the surface, it can cause friction with the opposing surface, causing a polish effect on this portion, which we would call as the bone eburnation. EBURNATION. Okay, so that is osteoarthritis. Next, we go to slide 196, which is rheumatoid arthritis. Okay, so rheumatoid arthritis is an autoimmune disorder or autoimmune disease, which we would see in the joint. And this would also cause destruction of the articular cartilage as well as that of the bone. And it can cause the formation of a fusion of joint surfaces, which we would call as ankylosis. Aside from joint, lesions, we also see skin lesions, heart lesions, blood vessels, and lungs would be affected. So what would be the culprit here? So because this is an autoimmune disorder, we would see the presence of an antigen, which we would call as an arthritogenic agent. It can be microbial or it can be a self-antigen that causes the formation of antibodies. So there are two antibodies here. We have the CCP, okay, or the citrullinated peptide antibody, and then 80% of patients would have the rheumatoid factor, which is an IgM or IgA antibody that would bind to the Fc portion of the IgG. Okay, so patients would also have genetic susceptibility. So in 50% of cases, they can have the HLA-DRB1 susceptibility gene. In some cases, you have PTPN22 gene susceptibility. So mediators can be present. Okay, if you're going to look at the slide, we would see the presence of here. So this, let us try to look at the other areas. Okay, so you have bony trabeculae. This portion is the interesting area. Okay, so you can see the presence of the surface to contain inflammatory cells, and you have granulation tissue, blood vessels, mononuclear cell infiltrates, and then you have fibroblasts. Okay, the inflammation here would be caused by the presence of mediators like tumor necrosis factor, which is the most important among them, as when they are going to use a TNF antagonist, it is very effective for rheumatoid arthritis. We have interferon gamma, which would activate the macrophages and synovial cells. And then, so this would be the synovial area. Here. So this would be the synovial area, this portion. So you can see the synovium. Usually for the synovium, it's only it's a single layer. Okay, you can see the presence of the synovial cells. It's similar to the mesothelial cells. Okay, but in this case, you would see some synovial cells to be increased in number. Okay, there's the interleukin-7, which would recruit neutrophils and lymphocytes, okay, or monocytes. You can see the presence of segmenters, and then you have lymphocytes. We have interleukin-1 and tumor necrosis factor, which would it would cause the release of proteases from synovial cells, and this is the one that destroys the hyaline cartilage. And lastly, we have the RNKL, which would so you know the function of the RNKL. Okay, it causes bone resorption, so which we would see in this particular areas. Okay, so so in this case, we would see inflammation, chronic inflammation at that. We have mixture of mononuclear cell infiltrates, histiocytes. Okay, and then what is very, very significant in this case would be this portion. Okay, so in this portion, you have something like a polypoid tissue. Okay, this one is a polypoid tissue that would arise from the surface. So this is what we call as the pannus. Okay, PANNUS. So it's a synovial overgrowth. It would show the synovial hyperplasia. This one, there's synovial hyperplasia. We have the presence of granulation tissue. Okay, so you have blood vessel formation, fibroblast, histiocytes. Okay, so this is pannus. So the pannus here is one of significant reasons why our patients have pain. This pannus can cause can become a bridge, or it can fuse with the adjacent surface, causing fibrosing ankylosis initially, and then later on there would be bone formation, okay, causing bony ankylosis. Okay, so this is rheumatoid arthritis. Next we have gout. This is slide 13. Okay, so this one is very easy to identify, as you can readily see the presence of the crystals. So gout is a lesion that is caused by deposition of monosodium urate, okay, crystals in the different areas of the body, and this is associated with hyperuricemia. Although when we have patients with hyperuricemia, it may not lead to gout. Okay, and the reason for this is there should be it should go beyond. There should be more of the degradation, okay, of the more of the degradation and increase in the secretion that would cause the deposition of gout, the deposition of monosodium urate crystals into the different areas. Okay, so there are two types of gout. We have the primary and the secondary. When you say primary, it's associated with an enzyme deficiency, and 90% of cases it's unknown. 10% would be associated with the HGPRT, or the hypoxanthine guanine phosphoribosyl transferase deficiency. Okay, so secondary gout would be associated with a predisposing condition like the presence of leukemias, okay, because there's a lot of proteins. We have chronic renal failure, Lesch-Nyhan syndrome, which would cause HGPRT deficiency. So patients usually would have it 20 to 30 years after having persistent hyperuricemia. Okay, so persistent hyperuricemia. And those with primary gout, usually when they have hyperuricemia, they can have comorbidities, or they can have conditions like being alcoholic, okay, obesity, and they are being administered thiazides and lead toxicity. Okay, so the diagnostic feature for gout arthritis would be the presence of tophi. Tophi would refer to the aggregation of monosodium urate crystals. Okay, so this is the monosodium. These are the monosodium urate crystals here. You can see them easily. So they are forming crystals. Okay, so very easy. It's like they are the dead gamo-gamo. Okay, so they look like the gamo-gamo there. Okay, so if you see gamo-gamo, okay, crystals, monosodium urate crystals, this would be gouty arthritis. Okay, so now we go to the soft tissue pathology, starting with slide 22. Okay, so this was only touched in Robin's in neoplasia, so fibrosarcoma. This is the malignant counterpart of fibroma and fibromatosis. So this would originate from fibroblasts, and you can see the presence of spindle cells. So, and there would be the presence of atypical fibroblast, which would be different from the other fibroblastic nuclei. Prominence of the nucleoli, here you can see prominence of the nucleoli. So these are atypical fibroblasts. Uh, in some of the books, if you're going to read it, they would say herringbone pattern would be very characteristic for fibrosarcoma. Okay, so it simply would mean that you have to look for areas that would assume a bone pattern that is typical for the fish. Although sometimes it's very difficult to view them. Okay, let's try to look for one. Okay, so it would show interlacing fascicle formation. Okay, longitudinal, circular pattern, but this is more arranged in this array. There's this organization of that pattern. Okay, and then again, if you're going to look at the high power magnification, you would see the presence of atypical cells. Okay, so you have here pleomorphism, prominence of the nucleoli, okay, of these cells. This would be positive for vimentin because this is a mesenchymal tumor. Okay, so this one is what you would say as having the herringbone pattern. Okay, so there's a line here. Okay, and then it would radiate to one side, radiate to one side, radiate to one side, or radiate to one side. So that is the herringbone pattern in this case. Okay, so here, so it's like having a line and then it transects from one area to another. Okay, so this is fibrosarcoma. So next we have slide 23. This is rhabdomyosarcoma that's pleomorphic. So rhabdomyosarcoma is derived from the skeletal muscle. Okay, so there are actually three variants for rhabdomyosarcoma. We have the embryonal, we have the alveolar, and we have the pleomorphic. Okay, so 60% of cases would be embryonal, and these are embryonal and alveolar would be seen in children. Okay, this would children and adolescents before 20 years old. Okay, so but pleomorphic adenoma, rhabdomyosarcoma is the one that we would see in adults. Okay, so what happens here is that we would see the presence of fusion gene, wherein you have fusion of FOX01 to either the PAX3 or PAX7. So histologically, again, this is very easy to identify. Okay, you can see the presence of very large cells having bizarre nuclear features. When you say bizarre nuclear features, you have large ones with irregular nuclear membrane, multinucleation, hyperchromatic nuclei, very large cell, okay, cell body, okay, and they have eosinophilic cytoplasm, okay, which is very characteristic for rhabdomyosarcoma. This would be positive for myogeny, okay. Of course, vimentin would also be positive in this case. And then we have slide 25, which is liposarcoma. Okay, so for liposarcoma, this is associated with an MDM2 activation, okay, which is identified with P53 inactivation, if you remember that one. So MDM2 is an inhibitor of the P53. So in this case, for liposarcoma, MDM2 activation would be present. So first of all, you have to look at the area of the normal tissue. Okay, these are the normal adipocytes. Okay, so the adipocytes tend to have abundant cytoplasm. The nucleus or the nuclei would be indistinct. Okay, so this would be the abundant cytoplasm. This would be the nucleus. the nucleus. So they are very, very inconspicuous. Okay, now let's go to the areas that would show the lipoblast. So these are the areas with the lipoblast. Okay, um, you have to go for the high power magnification for you to appreciate, okay, its appearance. So you can see the presence of the abundant cytoplasm. Okay, but this time you have this large nucleus. If you're going to look to differentiate or to compare this one with the other soft tissue tumors, the nucleus of this particular tumor would be small in comparison. But you have to compare it with the normal adipocytes. So these are immature lipoblasts with uh, large nuclei for than the usual adipocytes, abundant cytoplasm still. So this would be positive for S100. Okay, so this would be liposarcoma. Okay, so sometimes they are you might not identify the abundance of the cytoplasm. Okay, so you have to look at some areas that would readily be identified as liposarcoma. Okay, so in this case, this would be the area. Okay, and then our last slide for you today would be slide 101. This is leiomyosarcoma. Okay, so leiomyosarcoma is a malignant tumor that would originate from smooth muscle, and for this case, one of the clue that I would give to you is that you would see the presence of smooth muscle fibers, okay, uh, accompanying this particular tumor. So you have smooth muscle fibers. These are composed of alternating patterns of smooth muscle fibers that would be atypical. Okay, circular, longitudinal, circular. They would be positive for the mean and smooth muscle actin. You would see a lot of atypia. Okay, so you have the very prominent pleomorphism of the nuclei. You can have prominence of the nucleoli. Okay. Here you can see the presence of pleomorphism. You have mitosis over here as well as here and this one. Okay, so you have a lot of mitosis in this particular case. Here you have mitosis. So in leiomyosarcoma, that would be one of the criteria for diagnosing leiomyosarcoma versus leiomyoma, the presence of a lot of mitotic figures and presence of pleomorphism. Okay, so those are the slides we have for today's session. So stay safe and good night.